I think we're at a transformational time in medicine and healthcare in the United States, really. And we're sort of beyond the point now where we can just bend the curve a little bit. We're at the point now where we have to start thinking about what are the paradigm shifts that we need to go through. And when that happens, usually you have a group that wants to go with it, and you have a group that is set in their ways and has certain ideas about how things are going to happen. So for me to come here and stand before you guys who are really coming up in public health, understanding that we need to treat these problems as population-based problems is a real opportunity and a treat. So thank you. During this talk, if you have questions, I want you to raise your hands and answer. I'm going to try to stay on a level that's in terms of an overview rather than a lot of specific details, although I will get into details if you want to. I do want to talk about Holston Medical Group a little bit. Can you all hear me in the back? My voice okay? All right. Holston Medical Group does and has, I think, built a model that's applicable in a lot of ways. It's not where we need to be, but it's moved closer to where we need to be than a lot of other models. So I want to use some of it as examples as we go through here. What my talk's about is value-based healthcare, and we're moving from a system that really rewards volume. And it's important to remember that all the time, that our system is based on how many of something you can do. So a surgeon makes their living off of how many surgeries they do. A doctor in their office makes their living off how many patients they see. And it's adjusted somewhat for complexity, but for the most part it's a volume-based system. Of course, it's a system that requires skill and training to operate in. So we have very highly educated people in these volume-based environments right now. And they're, quite frankly, very clever people too. And if you motivate them and incent them or incentivize them to produce volume, they will. And we have one of the most voluminous systems in the world of healthcare. It truly produces a high quantity of healthcare. And that's fine if you have unlimited or significant amounts of money and you have large economies that are turning over rapidly. You can afford to pay for a whole lot of volume in healthcare. Unfortunately, we're coming to a new time in history in terms of what we can pay for, and we have to start converting our view to a value-based system. And you'll hear that a lot, the difference between volume and value. I want to start talking a little bit about why it's important and why, in fact, it's going to happen, and we need to get ready for it. This graph shows sort of why we need to change. We have a new population dynamic that's going on in America. So this isn't about how other countries manage their health care. This is about how America is going to have to manage its health care in the future, because it's about an American population dynamic going on a little bit everywhere, but definitely significantly here. The population in this graph, and it looks like I dropped out one of my lines somehow when it converted, but if you go down here to 2010 and draw a line up, somewhere in here we were at about 12% of people over the age of 65. When you get out into here, 10, 15 years from now, we're at a population that's at almost 22% in the over 65 age group. So what we're seeing is, between here and here, we're seeing a rapid increase in the slope of this curve over what traditionally has been the case. So the next question, this is the 85-year-olds, by the way, so they're going up a little bit, but you're really seeing the 60 and 65-year-old population increasing. Now we have in the United States, we have a system, as you know, especially a lot of our government systems, that pay for this group of people after the age of 65. The government, for the most part, provides a lot of the health care in this group. And this is the group that's expanding at an increased rate. And this is the group that you'll see uses a tremendous percent of the total health care cost in their care, because this is a group that has chronic diseases. They have hypertension, they have hyperlipidemia, high cholesterol, they have congestive heart disease, they have diabetes. So this group is a large consumer for obvious reasons. So does age make a difference? Healthcare costs per capita for persons greater than age 65 in the United States is 3 to 5 times greater than the cost for the other patients under there. So that tells you, if you think about our healthcare system in the acute model, wait for somebody to get sick and take care of them. We can do that with people under age 65 actually pretty well. But once you hit 65 and you try to use a model that doesn't have a significant preventative component in it, and you wait for them to get sick and you try to take care of them in the acute care model, 4 to 5 times increased costs for those patients. If our system doesn't change, this is what we have to look forward to in terms of increases in cost. I want to talk just for a minute about our system compared to the rest of the world, just so you can know where we're starting from. I don't know if y'all are familiar, and I don't want to give specific numbers out in a school that, you know, for the most part knows its statistical advantage and knows how to look things up, other than to say the United States has approximately a gross domestic product of about $16 trillion a year. And that's equivalent to all of Europe, probably bigger than most all of Europe. So we are by far the biggest producer of gross domestic product. Gross domestic product means all the money that's made selling stuff inside the United States for the most part. It's a very blunt definition, but that's what it is. If you look here, and there's a lot of different ones of these. If you look at them, they'll all be slightly different. They'll all have slight numbers. This one has the United States out here at about $7,000 per person. Some of them will be at 6, some will be at 5. None of them will be that way for the United States. So this is the amount of money that's spent per person at age, for a life expectancy of age. If you draw this number over to 78, you'll see it crosses the curve right there. So most countries in the world spend about $2,000 per person to get a life expectancy of 78. We spend about $7,000 per person. Okay. We have a different patient population. We have a different demographic. We're not homogeneous at all. We're a mixing pot, always have been. Have a lot of demands on us that aren't on others, and we're relatively successful as a country economically. So that's what you see. Is that a true gap? Could we, in a value-based world, push our spending down to $2,000 per person? I don't know. I guess that's the question that we're going to see what we can do. I want to talk just for a second about government spending, because I think it is driving this. This isn't really about the commercial payers, although they will follow, and it is an important piece. And again, the details of the data I want to leave out and just talk about sort of big brushstrokes. But the United States is approaching right now about 50% of all the spending in the United States coming from the government on health care. Depends a little bit on how you calculate it. So we're crossing that midpoint between private sector employer spending and entitlement programs. That's an important point. The government's payments cover these older patients I just told you about. And this is a number you can take home with you. And you may say 25, 75, or whatever you want. But about 80% of our spending is on about 20% of the patients. So there is a group, a target group out there that it has a huge amount of that spending in it, that if we did a better job with that group, we'd have a chance, and provided value in that group, we'd have a chance. If you really look at the details of where that money's going, where it's going is in treating those patients who are older, usually over 65 or approaching it. They have multiple chronic diseases. They're chronic, they're not acute diseases, so they're progressions of chronic disease. We treat those in the same system we treat somebody who had a car accident. They come in the emergency room or they go to their doctor's office, their meds are out of control, and so they're not getting enough fluid out of their body. It backs up in their heart. They can't breathe. They have congestive heart failure. They get admitted to the hospital for 3 days, get put on drugs to dry them out. If we could manage those outside the hospital, this is the highest cost setting to manage any disease process. It's designed to snatch somebody from the jaws of death. It's not designed to manage chronic disease. And so there's a tremendous amount of spending that goes in there. So then, I told you before, this population will double in the next 15 to 20 years, and will increase the spending if we don't do something 4 to 5. So this is the case for change, and this is the vocabulary of the nomenclature, and you've all heard it. It's being preached out there. Fee-for-service, which basically is a volume-based system, needs to go to fee-for-value. And I think everybody understands that fee-for-value is not volume-based. It can't depend on how many patients you see in your office or how many surgeries you perform. It has to be about health and outcomes and how healthy the population you take care of is. So what's going on in the background? Obviously, the system is flawed. We do have an insolvency issue with our government spending. Already we're seeing compression. You've probably heard of the sustained growth rate discussions that are going on in Washington right now. That will cut Medicare if it went through, or if it wasn't prolonged, I guess, or renewed. It could cut Medicare payments by up to 30%, growing towards that. 2% would bankrupt our system, probably 3%. So you can see why every year they just put it off and pass it on. So this is not something that needs to happen a year from now or 2 years from now. It actually needs to happen yesterday. We're behind the ball on this. So we have built the system on these economic foundations that reward volume. If you look at it from the physician side, it's about quantity. It's about not necessarily about having best practices. It's about how many patients you see. There's a lot of variation. There's not a lot of time spent, even by physicians, honestly, trying to drive variation out of the system and find out the best way to take care of populations of patients. There are limited accountability for outcomes. If you have two systems, and we have them in this area, you can look at them. We have two major healthcare systems sitting right next to each other. If you drive down Stone Drive in Kingsport, you'll see two billboards right next to each other, literally one on one side and one on the other. They both say best heart care in the United States, voted #1 or something like that. Well, that's fine, but the reason that happens is because we don't have systems of accountability, we don't have data. It becomes an issue of spin and competition and things like that rather than issues of accountability. And then the last thing is I want to say about the physician is physicians in a fractionated model that values volume. Physicians are more like laborers and less like professionals, okay? And our system's based on a doctor-patient relationship where there's a true duty. It's not a financial duty, it's a duty to provide the best care to that patient, to help them navigate the system, help them figure out how to stay healthy. And that's a professional duty. The more we create fractionation, the less that duty, the less that relationship stays intact. We know the less compliant patients are. We know that in bigger systems that are more segregated in that relationship, that their efficiency actually is lower. If you go out to the smaller areas where there's actually a strong relationship, the efficiency, there may be a lot of variation, the outcomes may not be any better. The efficiency of the system is already better. So we know the right way to move there. Hospitals, obviously have a lot of overcapacity because we use them for chronic disease states instead of the acute. The hospital of the future is an ICU unit for patients who have been acutely ill or have been in motor vehicle accidents or something like that. Obviously, we have a good system for that. I don't think anybody should criticize America for not having the best system in the world. If you are 35 years old and you have a heart attack, you want to be here. This is where you want to be. Because we have a great system and we won't hold back anything to save you and to preserve as much heart function as we can. So there's a lot of good things about our system, but the bad thing about it is it is volume-based and it doesn't take into consideration this population change we're getting ready to go through. And then, again, measurable outcomes are very difficult in volume-based environments. The employers here, as you know, the big employers in the United States are looking at other countries. And one of the reasons is healthcare cost. Healthcare cost is a significant portion of the cost of doing business in America. And again, when the biggest employers in your community are the healthcare systems, you know that something's going on there that needs to be looked at, okay? And they are. The employers are looking at economic reality. They're organized, they have leadership, they read their bottom lines, they understand what it would mean. Eastman over there in Kingsport, if it would just move its primary services to another country, and there's several that have offered, could probably put 20% more profit on their books than they have right now. So as these numbers grow and get worked around, how we manage healthcare is going to make a big difference to what our communities are like and what we have here. I want to talk about the patients a little bit because I think, the patients are so segregated out from decision making. They really are in a fractionated system where they don't know exactly what to do, even the ones that are educated. Even I see doctors fumble through our system trying to figure out how they're supposed to get from point A to point B. When I sit in my office and I see a patient and maybe if I look at in the corner of their demographic sheet, I can figure out what insurance company they have. I might have some chance of figuring out whether some of the services I'm providing might or might not get paid for under those systems. But for the most part, there's no time. We're in a volume model. It's time to move through. Patient doesn't know what they're paying. Maybe they know their deductible. It's going to cost me 20 bucks. They don't know it's a $300 visit that their insurance company is going to pay or their employer is going to pay. So we don't have patients in our current model. We don't have patients making cost value-based decisions about their health care, which needs to be fixed. And then patients, the satisfaction rates are really very low in our system, especially for chronic care. I want to move through this, and I do want you to raise your hand and ask questions if there's some specific things. So this is heading, the market forces are going to make us change what we're doing. I want to point out this third line down here about the amount of money. This $1 trillion of clinical risk needs to come out of the government system, and it probably will. It'll come out one way or another. And the question is, are we going to ration? Are we going to have the same care we have now, just a lot less of it? Or are we going to have something that's value-based? This $1 trillion represents about the government spend now. So in 20 years, they're going to double their spend. That's what they think. And they're going to try to figure out how to put $1 trillion out of that system back into the healthcare side of this. I'll tell you a little bit more about how the money's split up in healthcare, but I do want to say that Holston Medical Group and I think physicians in general are beginning to understand that what we need is more intellectual property in healthcare, not less. So we don't need bigger organizations and bigger structures in the business sense of healthcare. But what we do need is we need more organized delivery of the actual care, the care that you go to medical school for and you do your residency for. That's what we need more of in our system. This is just to summarize a little bit. The old systems, remember we have an acute care model. Our model is built after World War II. You get shot, you go here, 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 you get in the hospital, they save your life, and you go home. That's how our system's built. That's the center of our system. If you look at the biggest organizations in our system, they're wrapped around an acute care model. Where we have to go is to a chronic care model. We have to go to an outpatient-centric model. So everybody knows this. That's why the big systems that are acute care right now are trying to engage themselves in the outpatient world as much as they can. So they're buying home health companies, they're buying up physician practices. That's the modus operandi. I think now 85% of all cardiologists are employed by hospitals. So the hospital systems are beginning to try to figure out where in here they fit and their future is. Again, on the volume-based model, visits matter. On the value-based models, patients matter, outcomes matter. Okay. If you look at the kind of integrated management, which is over here, which is where we need to get, and you look at the different pieces of the organization, the big take-home is this increasing organization. Okay, less fractionation, more organization around outcomes in healthcare. We need to change the way we get paid. We need to change the role that providers play. Okay, they've got to bring the intellectual property that they got given to them when they went to medical school. They got to remember the promise they made, which was to have a duty to take care of the patients, and they need to bring that into the setting of populations and how we do get better care for people and do a better job. What value is quality over cost. It's a mathematical equation. We got to get great quality, and we got to do it for less money, and that's going to require that we put our brains to work to figure out how to do that, create the protocols. We've got to change the way competition happens, and I don't mean in a negative way. I mean we need to get some of the barriers out, let patients start making cost decisions, recreate that relationship that allows people to pick their way through the system in a value-based way rather than a volume-based way. And again, we can go down the list. I want to focus on the bottom, and I'm going to talk about it really for a lot of the rest of my talk today, is health information technology. There are two pieces to the puzzle we have to solve. One piece is the clinical piece, and everybody thinks about that. How do we create pathways that have little variation, put a doctor at in the top of a team. Everybody works to their level of expertise so that we're not overutilizing people at different levels. We create healthcare outcomes that are positive, and we do it in a cost-efficient manner. So that's the clinical piece that we have to accomplish. That's the piece that needs the intellectual property in it. The other piece, though, that we can't miss is that we can't have an understanding of quality and value without having the data that supports that. We are not a data-driven healthcare system. We're a volume-driven healthcare system. Value requires we have data because it's an equation. It's quality over cost. There's two pieces of data we need. How well are we doing, and what does it cost us to do it? You give clever people who are dedicated and devoted to getting this thing right, those two pieces of data, and we'll figure out how to do the system. We all together can figure out how to do the system. So those are the pieces, and they're all about data. The data has to come first. The data has to organize the structures around these new ways that we do things. Once the data is there and it's clean and it's high quality and we can do analytics on, then we have a chance to do the clinical piece. But the clinical piece can't happen without the data. And so we've known at Holston Medical Group, most provider groups know this. That's why a lot of them have moved to health information technology a long time ago. It was just because they had a duty to try to do a better job for the patient. It's never been paid for. It's always been an investment by whoever does it. So you can look at the different groups and you can tell a little bit about where they are in terms of their development of this. If they're getting if they're thinking they're going to get their EHR next year because the meaningful use money will run out next year, and they're thinking they're going to get into a health information exchange somewhere in 2 or 3 years because that's when the government says they have to, then that's strictly a volume-based approach. How are we going to get pushed forward? If you're really looking at this problem, you'd be in it immediately, and if you understood the urgency, you'd be in it immediately. Talk a little bit about patient-centered care, and then we'll go on to the health information technology. So what is patient-centered care? It's a personal connection between the physician and the patient, and I mean the second point here, it's a directed and managed team. So I say physician, but what I mean is the healthcare team. It's oriented towards the whole patient. It's integrated vertically, so it's hospital at home, it's home health care, it's assisted living, it's urgent care, it's infusion clinics, it's ER diversion, it's emergency room visits, it's hospitalization and surgery, and it's post-acute care. So it's a vertical integration of a system that currently is completely segregated. Even the physicians are segregated by specialty right now, separately from each other in different pieces of that puzzle. It's got to be accessible. Okay, one of the things we haven't done in our system is create environments where patients can be highly compliant. So accessibility is a key component of the quality piece of what we have to do. When you have a need for a physician or for your healthcare team, you have to be able to get that person or get access to that system. It does have to be convenient or people can't be compliant. You can't be compliant if a drug costs $400 and you have to pay for it out of your pocket every month and you're retired. You can't be compliant with that. We have to create convenience, both in access but also just in terms of being compliant. It has to be compliance producing, it has to be outcome based, and then the last one I put in all caps because I know that's like yelling at you when I put it in all caps. So it has to be measured with data. It has to be data. This is the patient-centered medical home, and if you guys want copies of this, it's about a 50-page PowerPoint deck that really explains what this is about. This is an attempt, and this is what Holston Medical Group has been involved in. This is an attempt to begin to get at the pieces that we need to be successful. So if you look through here at patient-centered medical home, and let me explain a few acronyms the way I understand them so we're communicating. When we talk about value-based systems, what you call what you're trying to produce depends on who you are. If you're a payer, you call it one thing. If you're a hospital, you call it another. If you're a physician group, you might call it another. Patient-centered medical home is a way of looking at value-based medicine from the point of view of the practitioners of medicine, so the providers. ACO, which is Accountable Care Organization, same basic idea, but it's looked at a little bit more from the payers and the hospitals. and it's a little bit more of a government word. It means, you know, how are we going to handle Medicare in the future, rather than how is Cigna going to manage its population in the future. But they mean basically the same thing. It's coordinating care across all these spectrums and vertically, like I said. NCQA is the National Council on Quality Assurance. It's been around for a while. They set standards. Remember, we got to have standards. We don't have standards, we don't know where we don't have accountability. If we don't have accountability, we've got 2 billboards on Stone Drive saying both of them are just as good as the other, and the patient doesn't know. Quite frankly, the doctors don't know either. So we've got to have some way to standardize some of these things, and then we've got to have good data to feed into them. And that's what this lays out. You can see, I'm just going to kind of run through the big points on this, but these are the components of any of these value-based systems. Access and communication, patient tracking and registry functions, that's how they're diagnosed and what they do, this is how we get the data in. Care management, so those are the clinical pathways. Patient self-management support, because a lot of this stuff we need to support the patients to do. Right now, if the patient doesn't come to your office, you can't get paid for taking care of the patient at all. We don't have a system for doing that yet. We're trying to get those systems, but they're really not mature yet. We got to have electronic prescribing, and I'll say even more than that. If we really were going to write this thing right, I need to prescribe electronically so that the prescription's sitting at the place where the patient's going to pick up the medicine. But I also need feedback that the patient actually picked up their medicine. And if they picked up 30 days and then they didn't come back for 60 days to get their second dose, their second prescription, I need to know that, because now I know that they managed to get 30 days worth of medicine into 60 days. Which tells me something about what's going on with them, and tells me maybe there's a reason. Maybe they couldn't get transportation, or maybe there's something I could help them solve. So we've got to track tests. We got to know if they had a CT scan at emergency room A 3 days ago and now they're in emergency room B. Not only do I need the results, because I probably don't need to repeat it. It's very possible I won't. But it helps me manage their care too. Referral tracking. Performance reporting and improvement, and advanced electronic communication. Everything on this for NCQA, just so you know, NCQA is going to be the standard by which you become a medical home. So for providers who want to say, I want to be measured by something, this probably is the dominant one it's the only one right now that really we can really use for any purposes. The dark ones up here are must-haves. You don't have those, you don't get to be a patient-centered medical home of any kind. The rest of these numbers you add together based on how many. So you can go to your local doctor group that you get your family practice care from, and you can measure all this stuff in how they practice and how they do business, and you can give them a score. And that score would tell you where they are on the scale of having a value-based medical system. Okay, it scores them whether they have electronic records. It scores them whether they have health information exchanges. So the dark ones are must-haves. The rest of them add up to numbers. Just so you know, there's 3 levels you can have, and I am going to talk a little bit about Holston Medical Group without trying not to blow the horn too loudly, but I think it's important to look at groups that are trying to do this, and we're not the only one, but we certainly are one of the leading edges in this right now. So there are 3 levels, level 1, level 2, level 3. Level 3 is the highest, means you're the most integrated and you provide the most care, so it is a level 3. It is the National Committee for Quality Assurance that we use as the accountability organization. So this is how the levels work. Level 3 is 75 to 100 points. When you add up all those points, like I said, I can give those to you. You have to have all the dark boxes, so all the 10 are required. Level 2 is 50 to 74, and all 10 boxes. Level 1 is 25 to 49 in 5 of the 10 boxes. So, you know, level 1 is achievable by anybody who really wants to try and invest in just a few pieces. You could get to level 1. It does take time. You do have to stand in line. There is paperwork. It's one of those things where you got to prove, you really do have to prove you're doing it. You can't just say you're doing it. HMG, and the last time we went through, got 98 points. So this is possible. This isn't a bunch of people sitting around in a committee saying, well, let's write up something and nobody will ever be able to hit it, which that was one of the criticisms of the accountable care law that came through, was that you couldn't figure out how to hit it. It was virtually almost impossible to hit. So just so you know, Holston Medical Group is the only and the first multi-specialty group in the state of Tennessee to have a level 3 rating. we have inside of our group, inside of HMG, the largest accountable care population in our entire region, including North Carolina, Virginia, and Tennessee. So it is something to be proud about, but it's also something to recognize that this can be done. This can be done by just a group of providers who decide that they want to do it. We also have the region's only health information exchange, and y'all have heard about, I'm sure you've heard, maybe you haven't, but there was a big regional health information organization that was really supported and was in this area called CareSpark, excuse me. Yeah, and CareSpark was a great attempt. What CareSpark was it was saying, let's all be a little bit, let's get together, let's get government grants, and let's solve this problem of how we exchange information so that one provider can get another provider's information for patient care purposes. And it went down the road like a lot of things do and never got any real substance or a business model that could support it. So it failed. What it left behind, though, was a whole lot of people that understood it was necessary and that model wasn't going to work, the model where everybody dumps their data into a central repository and then shares it. We're not real good at sharing in the model that we have right now. We do have an HIE now. It's got 300-400 docs in it. Hopefully it'll grow. It's, you have to do all the things you have to do to get a health information, to get anybody to do something that's changed that they don't get a direct benefit into their pocket. You got to make it free, you got to make it simple to get in and out, and you got to make it safe. So those are the guidelines for the new health information exchange, and it's beginning to grow. And then lastly, HMG, as Dr. Cray said, has been around for 15 years on medical records. We have the largest and the oldest intact data bank of patient records in the Allscripts system, and Allscripts is the second largest EHR system in the United States. So let me tell you what our goals are at HMG, because they ought to be our goals, all of our goals. We should be able to produce for our patients the best price care. We should prevent acute episodes to do that. We should make it easier to get and use care. We should optimize access, and we should integrate it. It should be the best quality care anywhere, which means we're going to use evidence-based medicine and we're going to measure our outcomes. And our vision is what the vision ought to be, that we ought to, for our patients that we touch, they ought to be the healthiest patients in America. Not the best quality care or any of that. I mean, this is what we're after, right? We're after health. Health is a lot more than whether you get your gallbladder taken out. It's a whole environment of things that we have to begin to put our heads around. I just want to show you this. This is our team. This is a team that's dedicated around, and this was in Medical Economics National thing, looking at Kingsport, Tennessee, or the Tri-Cities area for what they've done around team approaches to cardiovascular and diabetic care. So we're starting to treat these patients as having metabolic disease. We're following them. We call them. We make sure they get their medicine. We make sure if they're not taking their medicine, we know why. Their daughter didn't come over because she had to do X, Y, and Z. And we measure their, we weigh them in the mornings, and we call them if their weight doesn't come electronically back to us when they get up and step on the bathroom scale. So this is working, and it's showing that we can do some of these things. This is a patient portal we started about 3 years ago. So if you're a patient of HMG, you go see a doctor at HMG. You get on your computer, you click the app or whatever it is. I can't remember. I think you have to go to a website still on this, but we're getting an app. You go in there just like a bank. You put your name, your number in there, and boom, there's your electronic medical record. It's got your labs in it. It's got an email spot to talk to your doctor. You can correct things that are wrong. So if we forgot to take a medicine off or all those kind of things. So this is an interface where you get to engage, and that's a big piece of this. I say you, patients get to engage. So again, just an idea. I said we had a big group of annualized patients, but we have annual visits about 400,000. The reason I'm giving you these numbers, I'm going to give you some money numbers too, so you can kind of start thinking. If you remember, I showed you a number that showed in the United States we spend somewhere between $6,000 and $8,000 on a patient. Okay. Total number of unique patients. So these are patients we've seen in our clinics in the last 36 months. We don't count them more than once, so each patient's only once, no matter how many times. But it's about 200,000 patients, and that's 153 doctors doing about, and all the people that are with them 153, doing about 200,000 patients. So that's the math. So let me stop for just a second, and I am going to move on to the data piece, but are there any specific questions, or I don't want to, yes?
How is the system as it exists at the moment purely within the HMG database, the medical information?
So what I wanted to do with that was remove the obstacles, the friction points that I could tell in CareSpark had been part of why it didn't work. One of them was over dominance by a single group, so that groups couldn't feel confident or comfortable that their data would be safe, and safety of your data, safety of your interaction was important. So the answer is this is an HMG initiative, but it's not an HMG system. The system actually the way we did it, or the way we're trying to do it, is we got a contract, a reseller contract, with a software company that moves data. So the software company is called MobileMD. You may have heard of it. It's one of the big, Siemens just bought it. It's a big IT company. It's got hundreds of hospitals in its system. So it's a big company with a very good software product. All their software does is it moves, no matter what your EHR is, it moves that data back and forth, and it creates a virtual record. So instead of having all the data sit in a spot somewhere, the data sits in your EHR system, and it may be in your office, or it may be it may be hosted in Texas. Doesn't matter. When you go in, you agree to turn on the switches so that if another doctor is seeing a patient that you have data in your system, that system will go out and grab that data and bring it back in and create a virtual chart for that patient. The ownership of the data stays exactly where it is, and the ability to turn on and off the switches stays exactly where it is. So it's not dominated by any particular piece. It's a contract between the provider and the software company. The governance that lays around that is something that will be, right now, it'll be handled through the IPAs, ISHN and HPI. Highlands Physicians is a group of about 1,300 doctors, and ISHN is a group of, I think they have about 1,300 or so too. So these are big doctor organizations. They're contracting. They're related to the hospitals. They have what are called PHOs, Physician Hospital Organizations. So they're organized, and remember, one of the things we have to do is organize. So they're organized systems of providers that can decide whether they want to participate. So I don't know if that answered your question, but I was...
It's a wonderful concept, obviously,
yeah.
and being able to, I guess, one, make a large number of physicians aware of it, and then once subscribe to it, or
right,
is I suspect a pretty good challenge.
It's a challenge. So one is make it safe. One is make it turnkey so that there's not a lot of work that has to be done, which means you got to get other people to do the work of connecting and selling and informing and educating and making sure that it actually works. And we're using the EHR providers for that. So if you're an Allscripts system, I've made a deal with Allscripts to come in and help the connective piece of this. Of course, MobileMD is big enough, it has some of that on its own. The other thing we did was we said, this is about defractionating our system. So we're going to start right now. We've got an opportunity to defractionate. So for the HIE, we're going to have one lab connection. So we'll pick a national lab, but there'll be one connection. Now you can go with, a provider can go with any lab they want, but remember those labs will come into their EHR. Then they'll go into the HIE to connect directly into the HIE, and that gives the lab company a tremendous benefit, because most of these lab companies have to connect to every single EHR. Now they connect one time to an HIE, so it's a lot less expensive. So we've been able to take that contract, that connection contract, and turn it into dollars. Savings on the lab company part that we can then give, which is what we're doing, giving it away, so that the cost of getting in this HIE is less than $30 a month per provider. So get the cost down, make it safe, make it easy and convenient to set up and use, and so it's growing, and I hope it'll be a good thing. So yeah, I mean, and the more people know about it, the better it'll be. Yeah, no, it's very important. Yeah.
In a follow-up to that, you talked about the provider and the electronic record, but not the patients. So
yeah.
Was another issue in CareSpark was this confidentiality of my patient data and security
yeah.
of patient data and ownership of the medical record, quite
mm-hmm.
frankly, for the patient. patient rather than the provider.
Yeah.
So how are y'all?
So the two things. One is, and Google and United Healthcare both have a system for a patient-generated electronic record. So you can go in, I think it was Health Vaults or something. There's been a lot of companies that have tried to build these patient records where the patient goes in and their doctor dumps their data into it and the patient cleans it up, and it can kind of be like their vaccine registry and their allergy registries and all that. None of those have really worked, and they're all closing down and failing. The idea that the system that's going to be the accountable system, the one that's going to determine what outcomes are and all of those things, are going to be something other than a collaboration between the patient and the physician probably is not a realistic thing to think. There's too much data that has to be corrected. The record has to be understood in the context of, training. So there's a certain amount of it that could be done that way and a certain amount of it that obviously needs to have provider input. So I think the systems that are going to survive are the ones where there's a strong doctor-patient relationship that creates a record that's understood by both the patient and the doctor. Now, legally, if I were to hire you to write a book, and I said, I want you to write a book about X, Y, and Z, you wrote the book, then I would have hired you to write a book, and I would have the right to have the book. But you would have the right to ownership in the intellectual property because you wrote the book. Okay? It's your book. I just paid you to write it. That's a little hard to understand in the law, but that's basically the way it works and why people argue about, trademarks and patents and who owns what piece of this movie and that movie. You have to assign your right away, or that belongs to you because it's a creative work, and it required that you put your intellectual property into it. In the state of Tennessee, the person who creates the record or the document or the book or whatever it is, it belongs to them. It doesn't belong to the patient. Obviously, there's no reason to have it except for the patient. The patient has 100% access to it at any point. And my argument would be is it needs to be a patient-interacted thing. The patients do need to look in it. They do need to say, are my medical records right? They do need to get a copy anytime they want. They need to have a summary of what happened at their visit. So it needs to be 100% transparent, but it needs to be a combination of those two things. The privacy issues and all that kind of stuff, I have privacy issues around my bank account, but I use the internet to do it. And I think we have to get over our concerns about whether or not somebody's going to know whether we have herpes. And we know that's in our record, and we're scared to death that if that record were on the internet or someplace else that somebody would get it. Well, it's not any safer in your doctor's office when it's on paper. There's 7 people that pick it up every day and read it and look at it. There is a ability to control security with computerized things that exceeds anything we could have ever done before. But it is a depersonalization problem, and I think it's one that patients are going to have to engage themselves in. Our MyHMG has worked wonderfully. We have some patients won't use it, but most patients get on there and use it, and they email back and forth. It's completely secure. It meets all the qualifications. But I agree with you. That was a problem with CareSpark never addressed. Yeah. Did that answer your question?
Yeah, I think
Yeah.
so. So your patients are opting in, or you're not requiring them?
So we're doing, yeah. Basically, the way that we're going to handle the HIE is when the patients come in and they get into MyHMG, which is our portal system, they'll have a way that they can decide whether they want their data shared with other doctors. Now, I have never had a patient say, I don't want you to share my data with another doctor who's taking care of me. It just hadn't, it hasn't happened. Occasionally it happens when they're getting divorced and the husband has one doctor and the wife has the other, but other than that, yeah.
We sign a paper all the time.
Yeah.
I didn't know if that was a...
Yeah, it'll have to be. It is a legal requirement, but whether you treat it as an opt-in or an opt-out is not a legal requirement. But you do have to do something to get the permission. Yeah.
Thanks.
Yeah, thank you.
Not to dominate this, but I'm
Yeah.
fascinated.
Yeah.
I am an HMG patient, and I was not aware of my HMG, so
Yeah.
it might be a good
I agree.
comment to let us know, that whole 200,000 people know it if you could.
So we are in the process of that, and there's probably about I think there's about 30 or 40,000 people that are on it now, so it's growing very rapidly, and we're trying to get the word out. When you go into an HMG office, right at the checkout, there's the brochures and everything, but if the checkout person doesn't say, hey, have you signed up for my HMG, or if your doctor doesn't say it, we haven't gone out and put billboards up or sent out mass mailings. But I agree with you. This has to move faster. All organizations have internal inertia, or whatever you want to call it, that kind of keeps things from happening. And developing these kinds of things are scary for patients. You know, a lot of them, when they're first confronted with the idea that they can go on the internet, they have 5 minutes worth of questions or 10 minutes. So the girl at the front, if she got a line of 4, anyway, you know the thing. It's not.
But a more relevant point, I guess, really not my personal point, is though that, but using my example, if indeed now I have the information so that I can access my HMG through the internet, I can then provide that to another physician. Isn't that right?
Absolutely.
Well,
Well,
we might expand your
yeah.
exchange.
You have to be, now he can get it, so this is called they have a legal requirements called break the glass. If we have our system out there somewhere, and there is a physician who's seen you, let's say you come in unconscious to the emergency room, they can get on our system and break the glass. They can get your data, but they're going to have to justify why they did it and what happened and things like that. But yeah, no, it'd be much better for doctors to be able to come in. The HIE will solve all the problems of this, but you could share your information. I'm not telling you to, because the passwords and all those things obviously are how the security works. Right. So, yeah. Yes.
Could you talk to us a little more about the patient self-management support that you touched on earlier?
Yeah, so there's pieces of this puzzle that we know how to do, and we kind of have known it, but we haven't done it because it hasn't been incentivized. There's other pieces of the puzzle, quite frankly, I don't think we know how to do yet. And this area of how we motivate and how we empower patients to engage in the parts of their health care that they need to engage in to really improve the way the system works for them is one of those areas where we're just developing, I think. We're guessing a lot about how that ought to work. We don't have a lot of data on it. There isn't a lot of data, and it's an area that needs to be developed. So, what we're doing is we're giving patients access to things like a computer if they can use it. We're giving them a telephone number of somebody they can actually call when they have a question, a real person, not a 12 numbers or something like that. We're trying to focus on the 20% of those patients out there right now that are in the value-based groups. So every one of them ought to have a case manager. They ought to have a PharmD because they're probably on 17 or 18 medicines. You know, the average patient in our region around here can be on up to 16, 17 medicines, depending on what numbers you look at. These are medicines that interact with each other. They have blood levels sometimes they have to get. I mean, the patient has to have somebody who's helping them. If we're going to empower them to even care about what that is, they have to have somebody who's constantly monitoring and helping them. So we have PharmDs in our system. When I showed you that picture of the group, there are PharmDs in that group, and there's PharmDs in that every patient in our medical home, which is 24,000 right now, has a PharmD assigned to them that goes through their medical records and their chart and looks at what medicines they're on and whether they contraindicate each other and those kind of things. So without skirting your question, I think the answer is we need a lot more work done in that area, and then we need to be able to measure whether it's working or not.
Do you currently have case managers for patients?
Yes, we do. So if you're in our patient-centered medical home, you have a case manager assigned to you. And our family docs and our family practice and internal medicine are the team leaders. In the team, there's a range of other people. So there's a PharmD, there's a nurse, there's a case manager. There may or may not be a social service person or a front office manager, depending on how the system's working. But they're assigned to a specific population of patients. Yeah. Yes. Okay. So let me, I don't want to take too much time, but let's talk about the data for a minute. So again, I've mentioned why we need the data. I just want to focus on it one more time. Our current system is requiring solutions that the current system can't provide the solutions that we need to get this value base. We have to vertically integrate. We have to switch our focus to outcomes. And this last line, though, is the critical piece. And if you want to look underneath everything, what is it they say? Follow the money. If you really want to know why a lot happens the way it happens, you have to look at where the money flows. And our system has a lot of money that flows through it. So, and there's a lot of people that have a big interest in the status quo. So what's going to happen is that's going to be, that power of the status quo is going to be challenged by new contract systems, new payment systems. That's what ACO payment models are about. That's what gain share models are about. Right now, Holston Medical Group has 4 at-risk models. So if you come to me 3 years ago and said, how do you guys get paid? I would have said, well, if we do surgery A on you, we get X number of dollars for that. Now if you come to me, I'll say, well, the way we get paid is if we do all these quality measures on you, and if our cost of providing that care is lower than market, then we're going to get the difference between those two numbers. And this is what I think it's going to be, because we've done the math on it. And so that's the way that things are changing. And those contracts are going to force, because they have the gain share piece in there, they're going to force cost control. And the question is, if the cost control goes with a quality indicator, so you don't get the delta on your cost unless you hit the quality, now we've got quality and we've got cost, and we got the equation for value, which is quality over cost. So data is going to be the currency of exchange. So in the back of everybody's leadership minds out there who have a CFO in their group, and everybody does, the CFO is looking out at the world and going, you know what? If we can't manage our data, we're not going to get the contracts, we're not going to hit the contracts, we're not going to be able to work in this new environment. So if we don't have data, we're never going to get to the other steps. I'm going to talk a minute about our HIE. I think it is the difference between the value-based system and the volume-based system, is data has to be the underlying piece that starts it. It's essential and urgent. It has to function across systems, okay? It can't be a system that says, if you don't go to hospital X, you don't have any data, okay? We have all the data and it's in this system. In order for this to work, there has to be a way to control cost, which means the contracts have to break things up in a way that you can get at the cost drivers in the system. Hospitals are cost drivers in the system, and obviously I feel like we've got to have systems that run across them so that we can really get our patients the care. So data management's the key. Clinical integration's the key to value. It has to be across populations, must be amongst and across providers. It has to be professional, meaning that it needs more intellectual property, not less. We need more professionalism and less vocationalism in our system than we have, more summation and less fractionation. And we're obviously already behind the 8 ball. Health information exchanges are part of the change. Look at number 3 down there. Build community-wide clinical workflows to bridge care settings and drive outcomes. So in our HIE, if you're in it, okay, and you're a doctor, you can put an order into the HIE that'll flow out to wherever it needs to go. Maybe it needs to go to a pathology office, or maybe it needs to go to a lab company. If you're in the HIE, right now, if you're an HMG and you want to refer a patient, let's say you want to refer them to a doctor that's in Johnson City for reproductive endocrinology, let's say. You've got to pick up the phone, you got to call his office, you got to find out what day the patient can come in. There's a whole bunch of work that goes into managing that system. If you're in the HIE, the schedule book's right there. It opens up when we try to make the appointment with the repro endo guy. His schedule book opens up, and we can put the patient in there and tell him right there, you've got an appointment for 2:30 tomorrow afternoon. You're not in the HIE, guess what? You're probably not going to get a whole lot of referrals out of here, because the system's going to have to then convert to paper. So being organized and being together means, yeah, we get to keep track, we get to be accountable, and that some people don't necessarily jump at the opportunity to be in systems that do that, but you also get to now integrate. So we're going to leverage the strengths. The last item down there is clinical research and data revenue streams. I'm going to talk about that a little bit. This is how the HIE works. And by the way, our HIE is housed at a data center. The data center is located in Virginia, Duffield, Virginia. It's in Duffield, Virginia, because the Virginia Tobacco Commission, when it settled its case against the cigarette companies, got a huge sum of money. And they've decided that they're going to try to use that money to build better health care in some of the regions where people, quite frankly, smoked a lot and had a lot of issues related to it. So this is an area where two electrical grids come together. There's enough fiber in the ground, which Virginia paid for, that it qualified as a site to have a very high-level, highly secure data center. So that's where it sits. It's called One Partner. All it is a place to store data. It's a hotel for servers is what it is. But that's why you see One Partner written up here. So everybody in this first grid over here, everybody shares their data through that virtual method I told you about. We do referral coordination. We engage our patients through the HIE. And then this last one's really important because this circle right here is a big piece of what's broken in our system. If you take care of a patient in a hospital right now, you can have all the electronic integrated record you want. But if you can't get any of the data that's in the hospital back into your system, that patient leaves the hospital and has at least a couple of days where they're flying by the seat of their pants. Because it's possible the doctor that's taking care of them on the outside and the doctor that's taking care of them on the inside have a gap in terms of how they can do that. And that's what readmissions come from and things like that, which are big drivers of cost in our system. We have to be able to integrate this admit and discharge planning. It has to be physician integration so that there's a handoff, and the doctor inside the hospital actually hands it off to the doctor outside the hospital. And we don't have that right now, believe it or not. Again, this just tells you got to have a patient index, all the things CareSpark had to have. You guys have all heard about this, but it's not an easy task, but it is a doable task. And the main reason I'm putting this up here is so you can see it's doable, okay? So you sit down and you map this stuff out and do the hard work, and you can actually do it. So this is, and these guys haven't agreed to be in here, so I'm not, please don't think that every one of these people are in. They're not. These are people I'd love to have in. So this is a big group of doctors that practice mostly at Mountain States hospitals. These are at mostly Wellmont's hospitals. These are medical schools. You know, anybody that provides care ought to be able to interact with this. We ought to be able to expand and at least give them portals. This is the state HIE, so maybe the data goes in that the state needs to get to figure out whether it's running its Medicaid program right. Okay, it needs data to figure out whether it's running it right. And then you can see all kinds of EHRs can come in, the lab companies over there. So, and then the only thing I have to add with this one is it's still, you know, obviously there's a lot of ways this can work and it can do all of these. But these two pieces down here are critical. Research and clinical trials and third-party analytics. So this is now we got the data, what do we do with it? We improve care and we prove that we improved care. And those are the two model pieces at the bottom there. So this, I just put a picture of the ATAC Center up here. State of the art, this is where the data goes. And then finally, I thought I'd just throw some numbers out at you. We can talk about them a little bit. So GDP in the United States, I think I said 16 trillion. What's a trillion? 15 trillion. Healthcare overall, about 16% of that total spend. Most countries spend 8%, something like that. We spend 16. About 25% of that is the government spends about 25% of its spend on healthcare right now. It spends about 25% on a lot of other things, but the 25% on healthcare is pretty much fixed and growing every year. Providers, so I'm talking about all the people that actually interact and do the provision of care, the licensed part of the system that provides care, usually is about 15 to 20% of the spend. Hospitals about 30% of the spend, and so you can see about 50% of the spend on healthcare is in the other category. Not hospitals and not providers, but it's all the other pieces of the puzzle that you have to run our current system. So in the next 15 years, we expect the spend, even with value-based, it's going to go up. But if we don't do something, it's going to go up by 25%. That's a 100% increase in the government side. And some people are already estimating it's over 50. Military spending this year is going to be 25% of government spending. But I want you to look at it in terms of GDP. It's 3.6%. So you got to keep these things in perspective about where the problems are. The biggest employers in our region are all healthcare systems. Okay, they dominate. It's what we do for a living. It's what our communities do for a living. And then I love to put this picture up here. I think, you know, you have to consider from the government's point of view what is going to happen. And what's going to happen is either the private sector is going to come up with some solutions here, or the government simply is not going to be able to afford to do it the way it's going to do it, and it's going to have to adopt another system. And I think Obama has done, and the Congress has done. Maybe they haven't created a law that I can say, boy, that was great, and we can do all these things, and it's going to be successful. What they've done is they've said the time is now. We have to do something, and if you don't do something, go experiment. Go do the stuff you want to do. We don't even know if you'll be successful. If you're not successful, we've got an idea about how it's going to go. If you are successful, then the official word is more power to you. I think that's a good thing, and I think this is the question. Are we going to have a government-run system? Are we going to ration? Is it going to be run by bureaucrats, or is it going to be doctors and patients working together as teams to produce value? Are we going to be able to get the data that we need and organize well enough to really show that populations are getting more healthy? So anyway, that's the end of my talk. I can take questions, or are we out of time? I didn't really watch my watch very well. We okay?
I think we have a few minutes.
Okay.
We have about 5 minutes if there are questions or comments. Thank you.
Okay. Thank you. Any questions, or? I hope I didn't overwhelm you with the Obama picture there at the end. It's when he's wearing the doctor jacket with the stethoscope. That's
It said HMG on there, didn't it?
it's yeah. We actually invited the president. Of course, we didn't expect him to come, but we have an annual meeting every year, and Phil Rowe usually comes, and the local guys usually come, because it really is a little bit of a knockdown, drag out, where we get all the different players to really say what they think, and so we thought it'd be great to have Obama. We'll still get him there
I
sometime.
have a comment to ask you, maybe
Yeah.
ask you, Dr. Fowler. Could you give us one or two, maybe give a couple of your thoughts on what role would our students potentially have in the future as you see it?
Yeah. So there's an endpoint out here, and again, I tried to show a little bit about some of what the endpoint could be versus maybe what else it could be. You know, the accountable care, as it works its way down, is going to end up in a very specific model. It has to end up in, and that is, it's going to end up in some sort of capitated payment system. So there will be an amount of money that will be spent on health care in the future. That health care has to be that money has to be squeezed into a system that provides the best health outcomes, the healthiest communities. That's what we have to do as providers. So public health is going to become health in America. It's not going to be a unit of what we're trying to do. It's going to be what we're doing. Okay, we have to get out. We have to understand that what health is for people is more than whether they get their gallbladder taken out or they get their hypertension controlled. And it's about data. It's about statistics. It's about understanding how to improve health across demographics, across language barriers, across all the other things that I think you guys have been involved in for an extremely long period of time, and we need more of it, not less of it, in the system. So it's a growth industry, in my opinion, to get at the data and get at the accountability of how we do things better in public health. So, okay. All right.
Any final?
Do you think it's necessary to have a business or a clinical background along with it?
Yeah, I don't think either of those hurt you, okay? And in the complexities of life in our economy and our environment, maturity of perspective is critical. And those things all allow perspective to mature, all the things you just talked about. On the other hand, I don't think it's essential. And I think the key is, I think, going to be, there are some areas that you're going to probably really, really need to be on target in. And one of them is this sort of informatics model that's developing. What do we do with all the data we have? How do we manage it? How do we probe it? How do we develop hypotheses about what's really happening behind the scenes? So I think that piece, from my point of view, that would be the thing I'd be hiring you guys for. Help me with my informatics, help me with understanding this. Obviously, a clinical background's going to make a big difference in the way we talk to each other. A business background means to me, that you understand how to be a service provider. And so if you run a department in a company that I'm working in, I expect that department to provide services towards the end, which we're trying to get at, which is health and patients and things like that. So, yep.
Okay,
Okay, thank you.
very much.
Yep.